Well, thank you, Susan, for your kind words, much of which was undeserved. Many of the things I have accomplished have been in the company of great people in Canada, New Zealand originally, but the last 30 years in Canada. Collaboration in asthma research is key. As I've been thinking of the 50 years that Asthma Canada has been involved, it's remarkable to see an organisation that has that drive and energy continuing through from the founders to the present time. So I, again, offer my congratulations to all of you who founded and have maintained Asthma Canada, doing all the great work that it's doing in advocacy, in education, in research. I mean, your record of 50 years of service to the community is outstanding, and I'm delighted to be here to help you celebrate this great occasion. When I was asked to speak tonight, I wondered, where were we 50 years ago? 1974. Interestingly, 1974 was when I suddenly found myself launched into the field of asthma. I'd spent the previous couple of years at the University of Washington, Seattle, as part of my research training, but not in asthma. I was studying physiology of dogs' circulations and rabbits and monkeys and a few other creatures that I won't name, but not much in the way of clinical work at all. My training was understanding the physiology of the pulmonary circulation. I was offered a position back in Dunedin, New Zealand, which was a clinical position, and I thought, well, perhaps I should experience a little bit of clinical medicine before going back. And through the arrangements of my mentor, Tom O'Donnell in Dunedin, I was allowed to spend a month in Edinburgh, Scotland, with Ian Grant, who will be well known as one of the asthma gurus from 50 years ago. I do remember one major faux pas that I made when I was there, because one of his colleagues said to me one day, why are you here? What are you doing for this month? And I said, well, I've spent a couple of years in the States, and I thought I should see a bit of English medicine before I went back to New Zealand. Oh no, you won't see English medicine here, laddie. This is Scotland. Very different, very different. But 1974, I'm back in Dunedin, and very shortly after arriving back there, Tom O'Donnell, excuse me, called me into his office and said, Malcolm, I've just been appointed as the Dean of the new Faculty of Medicine in Wellington. So I'm leaving Dunedin and you're going to take over my asthma clinic. Wow. About 500 severe asthmatics. This is 50 years ago when asthma was such a terrible disease for many people. It still is for many, fortunately less so. But in 1974, treatments were limited. Bronchodilators, more bronchodilators, nebulizers, theophylline, a nasty, nasty drug, but it worked, and steroids if you were in trouble. And that was it. It was a time of suddenly having to come to grips with how do we manage this condition which is causing so much trouble to so many people. It was a very well-organized clinic, and I learned a lot just as I took it over. But every patient who came in for their review had spirometry performed, so we knew what their lung function was. They were reviewed regularly. It wasn't a matter of, I'll see you twice and you go on your way. This was a continuing care asthma clinic. But over the next 10, 20 years, we did get improved treatments. We got chromoglycate, we got inhaled steroids, low dose, higher dose, too high a dose, all sorts of issues came in as we managed asthma. But there were a number of events which focused my attention particularly. One of them, a major event, was the death of a child. That always gives you pause for concern. A 12-year-old boy who said to his mother, I'll stay in the car when he came home from school because he didn't feel well enough to climb the steps, and was later found to have died. And a few months later, a 21-year-old died on the eve of his 21st birthday. These were both patients that I was looking after, and I thought we were doing well. And suddenly you say, why? What's happened? I contacted a number of other physicians around New Zealand, and it turned out every one of us had seen the odd one. And you think one, it's just out of the ordinary. We suddenly realized that there was an epidemic of asthma deaths occurring, very similar to the 1960s epidemic which occurred in Britain and in Australia and a couple of other places. And that led to major investigations as to what is driving these asthma deaths. So that was one thing that got my attention and really said, why? We start asking questions. Don't just accept, don't just treat. Get to the bottom of why this is happening. And that led to the establishment of an asthma task force, which I was part of, and led to a major study of deaths from asthma. Regrettably, we acquired a caseload of over 270 asthma deaths in a period of 2 years. But we learned a lot from that as to what was happening in terms of severe asthma, in terms of bad doctoring. I hate to say it, but that was part of the problem, not taking it seriously enough. And maybe there were medication issues, and that's when we identified the issue of overuse of bronchodilators, actually making asthma worse. But the other thing that was curious at the time, because I was involved in a few other studies and some of the pharmaceutical companies were working with new products. We had a new drug that you've never heard of, Sudexanox. And I was asked to undertake a small study of Sudexanox, which we did, a placebo-controlled trial. I had 30 patients in this trial, and as the trial went on, I said, wow, I can tell who's on the active drug. They're doing so much better. Several patients improved remarkably. And then we broke the code. Oh, patients on placebo were doing just as well as those on the active drug. There was no drug effect at all. And that puzzled me. I said, well, we talk about a placebo response, but that's not really the explanation. So there's one of those little things I tucked away in the back of my head. Well, how did I end up in Canada? I was fortunate to interact with Freddie Hargreave at McMaster University. We actually met on stage at a meeting in London, England. And our meeting wasn't exactly friendly because I presented some data that Freddie said, no, that can't be right. And come and talk to me afterwards, which we did. And Freddie said, you need to come and work with me in Hamilton. And basically saying, then I can really teach you how to do asthma research properly. I accepted the invitation. We spent a year on our sabbatical at McMaster back in the 1980s. Seems a long time ago now. I actually proved to Freddie that I was right, and he was very gracious about accepting that the research we were doing in New Zealand on children was actually showing a phenomenon that we hadn't observed before. But that was a great year, and that was when I understood Canada's a great place to talk about asthma. There's so many people interested. There's great research going on. There are societies and organizations interested in asthma, from Asthma Canada, or the Asthma Society as it was, allergy societies and so forth. And so the other good thing about a sabbatical is that it gives you time to think. You don't have to go to committee meetings. You don't have to teach much. And one of the things I kept thinking about was that drug trial of Sudexanox, where patients on placebo got so much better. Not all, but some. And when you have time to sit and think, suddenly one day the penny dropped. To be included in that study, you had to be using your bronchodilator only when you needed it. And before that time, we had many patients who were taking it 3 or 4 times a day, based on the principle that it's good to keep your airways open. So take your bronchodilator morning, noon, and night, and an extra puff when you need. We took those patients off their regular treatments so that we could put them in the Sudexanox study. And I suddenly went back and analyzed the data again. Those who we had stopped the 4 times a day beta agonist were those who improved. Wow, this was novel. And that led to undertaking a big study which actually designed when in Canada at McMaster as part of my epidemiology course that I undertook while I was there. Went back to New Zealand, got funded, did the study, and that's the one that showed that regular 4 times a day beta agonist actually made asthma worse. That was fundamental to a lot of change. It didn't come easily. I thought when we published the paper that the next day everybody would believe me. And it took about 5 years of debates and discussions and arguments, and some of them quite feisty, before the physician crowd understood that